68-year-old male fall off bar stool, so put that in the frame already. Neuro intact with a small ICH. So this is the essential cut here. So again, 60-year-old male fall off bar stool with this stiff spine injury that's obvious at 4-5. We talked about you want to do a pan scan of this patient because he may have thoracolumbar. It wasn't that high of a bar stool, but you want to be thorough. But also this type 2 odontoid fracture. So these are this is the pertinent image. I apologize for the video. Neurologically intact, 62-year-old male, John, France.
So this is a highly dangerous injury. I mean, that's what has to be recognized. Positioning on the table is difficult. They're often hyperkyphotic. How you position their head, how you get them prone. So this is a multi-level posterior fixation of the subaxial injury because it's an ankylosed spine. How you handle the odontoids, the next issue, because if we look through the image and he has motion still with the OC1 joint and the C1-2 joint, I'd want to preserve that for him. So what I might do here is fix the subaxial injury with multi-level, and I might connect him to the skull and take the skull fixation down at 6 months after the odontoid healed, because I would be leery of treating the odontoid non-op because there's going to be so much stress on it, but it might not be a bad idea. Your other choice is to flip him over and do an odontoid screw because his bone looks pretty good, but I might just connect him to the skull and take it down, no fusion to the skull, and take it down at 6 months.
I think that that sounds like a great plan. I mean, the key point to recognize is that this has a spine with dish. It's like an ankylosing spondylitis situation. It's going to be unusually unstable, and you have to take great care at not being too rough when you turn to the prone position. You should have pre-flip motors to make sure that there's been no compromise in the turn. So for the subaxial fracture, certainly a laminectomy infusion. I would not consider treating this from in front. I think that they do much better with the posterior approach, and you get more points of fixation. I think you have to treat the odontoid for the reason said, that since everything else is so stiff, there's going to be so much stress at the C1-2 level that it's very likely to fail. It's, if you want to answer a board question, it probably would be to fuse up to C1 because that is the more tried and true approach, though I'm very attracted to the idea of trying to maintain motion at that level. But that's an experienced surgeon's level decision to make.
Dr. Spiker?
Yeah, so the one thing that I would add to this is to consider an anterior fixation to make the flip safer, depending on the patient. So this is a relatively common fracture in the subaxial spine in people with stiff spines. We see a lot of these extension injuries at 4-5 or 5-6. And depending on the patient, I think doing a single level ACDF is really low morbidity and really makes the most dangerous part of the case, which is positioning, safer. So for this case, because of the large osteophyte, that may dissuade me because suddenly that becomes a bigger surgery. But it's an important point, I think, to think about in general with stiff spines is, does a really small anterior surgery make the difficult part of the case easier? And then for me, this is probably a C1 to T1 or T2. I'm going to make a really long construct here. I'm going to treat C2 operatively. I like the idea of going to the occiput and then coming back. You painted a picture of somebody who may not come back, so that pushes me to kind of do one and done a little bit, but it would depend on the patient.
If you're going to do that, Ryan, and you're going to open at C5, 6 and put a plate on for the flip, which I think is a very reasonable approach, you're at the same position for an odontoid screw. Why not put an odontoid screw up there? So if I was going to take that strategy, I would probably put an odontoid screw up at the same time.
Yeah, John, I worry a little bit about an odontoid screw at the end of a rigid lever arm there. Odontoid screws are not as strong as we used to think they were. And I mean, there's good biomechanical evidence. I think that Rick Sasso published initially. They're only 50% as strong as the intact odontoid. So I think, if you're going to be posterior, why not just do it all posteriorly?
Charles, anything?
Same, all posterior up to C1.
Okay, so this is what we did. So this is a very important point for residents and fellows. Have a couple people in your back pocket, okay, who you depend on and you can send things to. I swear I didn't send this to John France, but I thought he had a great idea. So we went all posterior, instrumented the occiput. Those of you who have worked with me, you see the occiput plate. That's what we use when we're not going to fuse. C1 lateral mass screws, and then all the way down. This video is not going to play, but if it did, it would show you that the odontoid can heal predictably as long as you align it. And then CT scan, I think it was about 7 months. We did a CT scan, and then we took the occiput C1 instrumentation out. Don't let anyone fool you. They never get normal motion, but definitely much less debilitating than occiput to cervical. And the nice thing about this was recidivism is real. He fell off again, and if the video played, you would see that the odontoid held up. So.